All right, so now we're on to vancomycin. This is much easier than aminoglycosides. So just a little review of vancomycin pharmacokinetics. It is a 2 to 3 compartment model, which means that you have to go through, it has to distribute out. And there's 2 phases of distribution that take about 2 to 3 hours. So the distribution phase, well, it should be over by about 3 hours. And from that point, then the elimination phase is there, and that is just a straight line. So it's first order kinetics. Volume of distribution, the one that we will use is 0.7 liters per kilogram. You'll find that a little bit different, depending on which reference you use, but for our class, we use 0.7 liters per kilogram. The half-life is around 6 hours, but that's going to vary extensively based on kidney function. Okay, so it is excreted. It's renally excreted, mostly by glomerular filtration. There is some tubular secretion, but mostly glomerular filtration. So levels are not going to be drawn until after that distribution phase, and that's why we can assume that it's a first compartment model. So we won't draw any levels until it has time to distribute out to the tissues. Vancomycin covers gram-positive. It is used for MRSA particularly. It is not as effective as penicillin is for methicillin-sensitive Staph aureus. Okay, so we should only be using vancomycin for MRSA. It does not have any gram-negative coverage. It can be used orally, but only for C. diff. So you won't see it used. You shouldn't see it used orally for anything other than that. Adverse drug reactions, we worry about nephrotoxicity. It is reversible, and it most often happens when you're using it with concomitant nephrotoxic medications like beta-lactams. So a common combination we use is vancomycin and zosyn. When we use those 2 together, you're likely to see acute kidney injury. You can stop the vancomycin, and usually the kidney function will go back to normal. Ototoxicity is a concern only with very high peaks, and we don't really see ototoxicity much anymore. And there are some schools of thought that think it was related to a preservative that was in vancomycin instead of the vancomycin itself. The other real side effects of nephrotoxicity is real but reversible, and we also have neutropenia and thrombocytopenia. And these are usually see these when you have patients who are on vancomycin for a long time. And it is reversible. It just takes a little bit of about a week to come back to normal. So some limitations as a general rule, the maximum amount per dose is going to be 2,500 milligrams to 3,000 milligrams, okay? So at my facility, we use 2,500 milligrams as the maximum dose. The maximum daily amount is 5 grams or 5,000 milligrams. So you wouldn't see more than 2,500 milligrams Q12. Okay, so we're going to put that cap for the 24-hour cumulative dose at 5 grams. Red man syndrome, not an allergy, please know that. There's a picture of what it looks like here. It is a hypersensitivity reaction that's due to histamine release. So we can pre-medicate with Tylenol or Benadryl to help with that. It's most often associated with infusion time. So we put a limit of 1 gram per hour on a vancomycin infusion, and that will help mitigate this red man syndrome. If your patient gets red mans, we can slow that rate down even more, usually over 3, sometimes even 4 hours, and that should resolve. All right, so therapeutic range. You have to know these levels, okay? Your desired trough for a mild infection like a UTI or cellulitis is going to be between 10 and 15. For more severe infections, we're going to push that up to 15 to 20. So how do we dose vancomycin? We do it the same way we did aminoglycosides. It's just a whole lot easier. So you need to know the dosing weight. The dosing weight will determine the loading dose. Then we'll calculate their creatinine clearance, their elimination rate, volume and distribution, and then we can estimate a dose and a dosing interval. So again, you see this slide up here. Know this slide, okay? For vancomycin, it's different than creatinine clearance and aminoglycosides. We use the total body weight or actual body weight to dose vancomycin, always. Know it, keeping in mind that you have that limit of 2,500 to 3,000 milligrams per dose, and you have a 5 gram Q24 limit, okay? So again, total body weight is what we use for vancomycin. Then we're going to calculate the loading dose. So the loading dose is going to be independent of renal function. Okay, we can give a load, and then renal function is going to determine how frequently we will give that maintenance dose. But the loading dose you can give irrespective of their creatinine clearance. So most infections are going to be 20 to 25. If you have a severe infection, it's usually we're going to limit that at around 25 milligrams per kilogram. In a young, healthy person, we may push that up close to 30, but usually 25 milligrams per kilogram for severe and 20 milligrams per kilogram for a mild infection like cellulitis. Calculate the creatinine clearance. Hopefully you got this from aminoglycosides. We know the formula for creatinine clearance. We use ideal body weight to calculate creatinine clearance unless two things. If they're obese, meaning they're 125% over their ideal body weight, or if their ideal body weight is less than their actual weight. Okay, so ideal body weight is the rule for creatinine clearance. Again, if they're over 65, you're going to round their creatinine clearance up to 1 if it's less, and then we'll cap that at about 120 milliliters per minute when we're doing calculations. So you calculate the KE. This KE formula is a little bit different than the aminoglycosides. It's 0.00083 times creatinine clearance and add 0.0044. This is your population pharmacokinetics, okay? This is based on what historical studies, not patient specific. We'll calculate the volume and distribution. That's 0.7 liters per kilogram. And again, this is a population parameter. So the volume and distribution for vancomycin, you can see, is much bigger than it is aminoglycosides. But it's going to depend on a whole lot of things. Obesity affects the volume and distribution significantly. Fluid status also does. So from there, we estimate the maintenance dose and the interval. You can do this the easy way. Just estimate the dose based on 15 to 20 milligrams per kilogram. Again, that's actual body weight, total body weight, okay? Your dosing increments for vancomycin are going to be in 250 milligram increments. And we use the same dosing intervals, Q8, Q12, Q18, Q24, etc. And we're going to dose based, or we're going to schedule their maintenance dose, their dosing interval based on their creatinine clearance. And you can see in the box here, okay? Make sure you infuse at the correct rate, so 1 gram per hour. And you can plug this in and do a double check. So we've calculated our population parameter, volume and distribution in KE, and our dose. And if you want to know what we expect the peak and trough to be, you can use this formula to calculate in. Again, remember that the T prime is your infusion time. Okay. So we measure a trough prior to the 4th dose, and we do that 30 minutes before the dose is due, and we consider the loading dose to be the 1st dose. Okay. We don't tip in the traditional way to dose vancomycin. We don't use peak concentrations, and we use the patient-specific parameters based on those levels. Okay. So measuring the concentrations. Here's just an example. So we've got a patient who gets a loading dose and 3 maintenance doses, and his next dose is due at 11 a.m. So he's had 4 doses. We're going to draw the trough prior to this dose. It should be done at 10:30. 30 minutes prior to the next dose. So how do we adjust the dose? Well, you can use 2 blood levels, just like we did with aminoglycosides, and you can use that using the straight line formula. You can determine what their patient-specific parameters are. If we use 1 blood level, which is what we most often do, then we're just going to dose it empirically. So if the trough is a little bit low, you can adjust the dose. If the trough is significantly low or high, adjust the interval. So you get more bang for your buck when you adjust the interval than you do by adjusting the dose. If the trough is high, significantly high, then we need to hold a dose and recheck a level before we redose it. Okay? So if we have to check vancomycin levels, if we're expected therapy going to be 7 days or greater, and after the 1st trough is therapeutic. So after we get that 1st level back that looks good, then we're going to check a trough at least weekly, and we're going to monitor that kidney function at least twice a week. Okay, so we're going to keep, if we start to see that serum creatinine rising, then we need to check a random or a vancomycin trough to make sure that they're clearing that drug and that they're not holding on to it, okay? So monitoring vancomycin, we use more frequent or intense monitoring if we're using a really high dose or if they have a life-threatening infection. Okay, so we're going to, like meningitis, endocarditis, etc. Or if they're on dialysis. So again, you follow the same rules, take these levels, plug them back into the formulas, that same formulas that we use for aminoglycosides, okay, to determine the peak and trough. Again, if you have a peak or trough that's just a little bit out of range, say we're looking for a trough between 10 and 15 and our trough comes back at 16, you can adjust the dose down a little and that should correct the problem. If that level came back at, say, 21, you need to hold a dose and recheck the level before you redose to make sure that they are clearing, okay? There is, we are using AUC dosing now. It's just a little bit different. And basically it's measuring the area under the curve compared to the MIC, which is the mean inhibitory concentration. So basically it's kind of a hybrid model of looking at peak and the area above the MIC. And I'm not going to go through this on this recording. You guys can look through here. You won't have any questions on this, but this will be a good reference for you. When you're using AUC to MIC dosing for vancomycin, you're looking at a number between 400 and 600 for an MRSA infection. And so you'll go a little bit higher for more severe infections, a little bit lower for skin and soft tissue infections. But basically the premise behind it is that troughs are only about 25% accurate. So we use this surrogate, and we have used troughs as a surrogate for this AUC to MIC ratio. It is more accurate, it's more patient specific. So we're going to look for a goal AUC to MIC ratio of 4 to 600. And I've given you an example here. You can work through it to kind of go through the calculation. It's just basically a very simple calculation. But this example will help you determine this. This is the ultimate. You calculate or you get the AUC that's current divided by the total daily dose, and then you set up a proportion and you can modify your dose based on this. If you work through this example, you won't have any problems. Okay. All right. Please let me know if you have questions. Hopefully this is helpful. It is a very fast, quick review. I've also posted some questions for you, some practice questions that you can look at along with the key.